Hi, I'm Princess Senate, conference producer at Technology Networks, and I am here to introduce our next talk, utilizing mesenchymal stem cells as potent anti-COVID-19 therapy in cancer patients with severe SARS-CoV-2. I am pleased to welcome Dr. Jan Leyfman. Dr. Jan Leyfman has been recognized as one of the top international researchers in oncology by the American Society of Hematology and American Society of Clinical Oncology. He has contributed to the development of several anti-cancer therapies that have recently entered clinical trials and new treatment recommendations of care. His successes have been recognized by the Goldwater Research Foundation, Sigma Z, New York Times, and Harvard Medical Schools. During the COVID-19 pandemic, he was recruited to join the Global COVID-19 Task Force to serve as director of the Immunology Division, which produced one of the first mechanisms for SARS-CoV-2 and COVID flu, along with therapeutic interventions for both. His work has been published as the cover article in the journal Shock and in the textbook Insights on a Post-COVID World. A warm welcome to you, Dr. Leyfman. Following the presentation, we will have a Q&A session, and we welcome any questions that you may have. Please ask questions using the Q&A system to the right-hand side of the video player. You can also use this feature to connect with attendees and discuss the talk. So feel free to take advantage of the chat system by introducing yourself and sharing your thoughts during Dr. Leyfman's presentation. You can also benefit from some fantastic supporting literature, which you can download for free below the video player. If you experience any technical difficulties during the presentation, please request help using the technical help icon in the menu on the left-hand side of the player. And I will now hand over to Dr. Leyfman to begin his presentation.
Thank you. Thank you so much for that warm introduction. And thank you so much for having me. I want to especially thank Technology Networks for having me as part of this groundbreaking 2023 Landscape of Cancer Research Symposium. Truly a pleasure to be here. So with that, let's begin. So the overview of my presentation is as follows. We're going to begin with a brief background on COVID-19. Then we'll transition to a discussion about severe COVID-19 and cancer. Then we'll speak about mesenchymal stem cell therapeutics in the context of severe COVID-19 and cancer. And then we'll discuss future directions. So let's begin. COVID-19 background. So COVID-19 is caused by the novel beta coronavirus SARS-CoV-2, and its rapid spread had caused a global pandemic that is now becoming more endemic by the day. Now, this viral infection has broad symptomatic presentations that affects most of the organs within the body. And this is all illustrated here, where you have the lungs, the liver, the kidneys, the brain, the eyes, the nose, the heart, the vasculature. But the spectrum of these presentations is very wide, and that is illustrated in the table here, whereby it can range from asymptomatic disease all the way to critical illness that can then ultimately result in multi-organ damage and failure. So this led to our proposed model for SARS-CoV-2. Now, in this model, SARS-CoV-2 acts via a direct and indirect mechanism to induce damage. So looking first at the direct pathway, you have the virus binding to ACE2 cell surface receptors present on all the organs shown here. The eyes, the nose, the lungs, the heart, the vasculature, the kidneys, the brain, GI tract, and the liver. In each of these organs, you have invasion, replication, and damage, and then you have secretion of IL-6. And this IL-6 secretion will go into your indirect pathway that I'll get into in a few minutes. And then in each of the organ systems shown here, you have resulting damage. So for example, in the nose, you have anosmia, which is loss of smell. In the lungs, you have dyspnea and alveolar inflammation. In the heart, you have a broad spectrum of manifestations ranging from myocardial infarction, which is heart attack, to cardiac inflammation, to atherosclerosis, to hypertension. In the vasculature, you have thrombosis. In the kidneys, you have acute kidney injury and or acute kidney failure. In the brain, you have altered mental status, stroke, seizures, brain inflammation. In the GI tract, you have GI discomfort and diarrhea. and then in the liver, you have hepatic injury. Now, going into your indirect pathway, you have the virus activating pulmonary macrophages that secrete IL-1, which then downstream results in secretion of IL-6. You have IL-6 coming in from the direct pathway. Then you have the virus activating antigen-presenting cells, which are defined as macrophages, dendritic cells, and monocytes, which then go on to secrete IL-6. And then you also have IL-6 coming from hypoxia, which is a result of prolonged or severe forms of SARS-CoV-2. Now, IL-10 is supposed to rein IL-6 in. But if you think of a seesaw, you have so much more IL-6 that IL-10 is unable to rein it in. And then this IL-6 goes and activates further downstream pathways illustrated here, where through cis signaling, you have it act on lymphocytes, and then you have an upregulation of pro-inflammatory pathways and a downregulation of anti-inflammatory pathways. You have IL-6 going and acting on the liver, which results in acute phase reactants. You have thrombopoiesis due to TPO. You have complement activation due to C3, and then you have decrease in albumin. Through trans signaling, you act on endothelial cells, and then this IL-6 acts on the vasculature as well, and that results in decreased E-cadherin, which results in vascular leak, increased vascular permeability, even more IL-6 production, which results in further amplification of this pathway, neutrophil recruitment, and monocyte recruitment. And then all of this taken together results in a cytokine release syndrome, which leads to inflammatory damage. So the analogy that I like to use is you have a person standing in the middle of the road, you have a bus hitting them from the front and a bus hitting them from the back. The bus from the front is your direct pathway, the bus hitting them from the back is your indirect pathway. And overall, this leads to systemic inflammatory injury. So now let's talk about severe SARS-CoV-2 and cancer. Now, cancer patients as a whole are an increased risk of severe SARS-CoV-2 infection because of their immunocompromised status. And according to the World Health Organization, cancer patients as a whole have about an 18% increased risk for severe SARS-CoV-2 because of this. And so herein we wanted to propose a mechanism that can somehow explain how SARS-CoV-2 infection and cancer interplay. And that largely results through hypoxia, because both SARS-CoV-2 and cancer result in hypoxia, and this leads to alterations in metabolism that results in hypersecretion of IL-6, and then this IL-6 leads to more inflammation and hypoxia-induced metabolic alterations and ultimately cell death. So looking at cancer patients for a whole that were heavily affected during the pandemic, and this is an example, are those with multiple myeloma. Now, multiple studies had demonstrated that multiple myeloma patients possess poor responses to vaccination, even after second dose of the vaccine. Now, this study really tried to look into why this happened, as it analyzed the serum antibody levels prior to vaccination, and then following the first and second vaccinations with both Moderna or Pfizer amongst 103 patients. 96 of them had active disease and 7 had smoldering disease. Now, these results showed that smoldering multiple myeloma patients responded better than those who had active disease, and only 45% of active multiple myeloma patients developed an adequate response, while 22% had a partial response. Now, after the first RNA vaccinations, the authors also observed that 2% of multiple myeloma patients would spike antibody levels that exceeded more than 250, and 250 is important because it was the marker used to define clinically significant protection, while 19% of those patients had levels only above 50. Now, after the second vaccination, 22% of multiple myeloma patients had a spike antibody level between 50 and 250. And so it was concluded that most multiple myeloma patients had impaired responses to mRNA vaccinations against COVID-19. In another retrospective single cancer study performed at the Leyfman Cancer Institute to evaluate COVID-19 vaccination trends in 579 cancer patients who underwent active treatment and previously infected with SARS-CoV-2 between the time period of January 2020 and January 2021, found that the acceptance rate of COVID-19 vaccination amongst 498 previously infected cancer patients was 54.6%. Now, of the patients with no vaccination, 76.8% received their first vaccine by April 17th of 2021. And then as of November 30th, 2021, 23.7% of eligible patients were boosted. So it showed that vaccine uptake was low amongst those that are previously infected with cancer. And so really at this point, I want to present our severe SARS-CoV-2 cancer model. Now, this model is very similar to our SARS-CoV-2 model, with one small change shown in the red box here. So ultimately, over time, patients affected by COVID-19 are prone to hypoxia. Hypoxia is also common in malignant tumors, whereby it alters cancer cell metabolism and also contributes to therapeutic resistance in various cancers. Hypoxia is also a trigger for increased IL-6 secretion, which then leads to an upregulation of the downstream pathways, increased production of cytokine release syndrome, and enhanced systemic injury and inflammatory damage. So all of this is further clarified mechanistically in the next slide. So I realize that this may be kind of busy, but I'll do my best to clarify and walk you through this pathway. So SARS-CoV-2 in cancer induce hypoxia that results in cellular necrosis and upregulation of the TLR4 pathway and HIF1 alpha. This results in increased secretion of IL-1 beta that stimulates NF-kappa B, that then results in mitochondrial dysfunction, secretion of reactive oxygen species, and subsequent inflammatory damage. IL-1 beta also stimulates IL-1 receptor to cause the alveolar macrophages to undergo pyroptosis that leads to inflammatory damage. Hypoxia, IL-1 beta, and HIF1 alpha then stimulate COX-2. And then this COX-2 catalyzes the breakdown of arachidonic acid into prostaglandin H2. Further breakdown of COX-1 and 2 results in the production of prostacyclin, prostaglandin, and thromboxane. And then hypoxic metabolic derangements results in the accumulation of misfolded proteins within the lumen of the endoplasmic reticulum, which then results in the activation of unfolded protein response, or UPR. This then activates an inositol-requiring enzyme 1, or IRE1, which then catalyzes the transcription of X-box binding protein 1, or XBP1. And this results in the secretion of IL-1 beta and IL-6 that then turns on downstream pro-inflammatory pathways. Additionally, hypoxia also activates protein kinase R, or PKR, like endoplasmic reticular kinase, or PER kinase, within the endoplasmic reticulum, which stimulates activating transcription factor 4, or ATF4, dependent transcriptional activation, which then results in further secretion of IL-6 to promote inflammation. And so, in addition, HIF1 alpha, ATF4, and XBP1 stimulate the release of vascular endothelial growth factor, or VEGF, and then VEGF contributes to pulmonary inflammation and promotes vascular permeability, resulting in pulmonary edema, which then further exacerbates tissue hypoxia. Ultimately, the goal of this is to show on a molecular and cellular basis what is really happening in the model on the previous page that causes the derangement of cellular processes and induces systemic inflammatory injury. Now, another question that arose is, what is the mechanism behind hypercoagulability in severe SARS-CoV-2 and cancer? And so SARS-CoV-2 in cancer, as I previously stated, stimulates IL-6 secretion, which then causes endothelial cell dysfunction. This results in increased vascular permeability, complement activation, and inflammatory damage due to the secretion of acute phase reactants. Now, both SARS-CoV-2 and cancer contribute to Virchow's triad, which is defined as hypercoagulability, endothelial cell dysfunction, and blood stasis. That in addition to endothelial cell dysfunction also leads to prolonged hospitalization, hypercoagulability, because in the process, one is releasing procoagulable factors. And ultimately, this results in a procoagulable state, which results in increases the risk for deep vein thrombosis and pulmonary emboli. So now let's discuss mesenchymal stem cell therapeutics. So one promising approach during the height of the pandemic was a cellular therapy that used mesenchymal stem cells that had yielded promising preliminary efficacy in COVID-19 patients. And here we showed 3 companies that have used these cells in patients during the height of the pandemic and shown profound efficacy. One of these companies is Pluristem, which did a 28-day follow-up from their earlier phase clinical trial in 7 patients with multi-organ damage. All of them made a successful recovery shortly after a single treatment. Now, this recovery persisted even at the 28-day mark, and all the patients remained COVID-free. Now, the company received FDA approval for a phase 2 trial for the treatment of 140 patients with severe COVID-19 and acute respiratory distress syndrome, or ARDS. Now, most recently, one of these companies, which is Mesoblast, had demonstrated promising results from their phase 3 clinical trial, and ultimately, as a result, received Fast Track designation from the FDA in December of 2020. So I know what you're thinking. Now, how does this therapy work and why? Why is it so effective? So mesenchymal stem cells act as immunomodulators, whereby they downregulate the pro-inflammatory pathways and upregulate the anti-inflammatory pathways. Now, most studies have also shown that they possess antiviral activity as well. And they also affect all the cells shown here. So let me walk you through this. So mesenchymal stem cells act on macrophages. They upregulate M2 macrophages and they downregulate M1 macrophages. M2 macrophages are responsible for promoting and stimulating anti-inflammatory pathways. M1 macrophage is responsible for pro-inflammatory pathways. So as a result, you're stimulating more anti-inflammatory pathways and downregulating the pro-inflammatory pathways. They act on dendritic cells, which have a role in secretion of pro-inflammatory cytokines. By you downregulating dendritic cells, you are decreasing the secretion of pro-inflammatory cytokines. They act on natural killer cells, and which have a role in proliferation, cytotoxicity, and secretion of interferon gamma, which further propagates a pro-inflammatory response. By you downregulating NK cells, you're downregulating interferon gamma, you're decreasing inflammation. They also act on B and T cells, where B cells are responsible for producing antibodies, and T cells are responsible for cytotoxicity and cytokine secretion. And in both cases, both of them are decreased as well. Now, the efficacy of these cells was further verified in a double-blind randomized controlled clinical trial. Now, this trial was developed to really evaluate the safety and explore efficacy endpoints of allogeneic umbilical cord mesenchymal stem cells in patients with COVID-19 and acute respiratory distress syndrome. So in this study, they had 24 patients with COVID-19 ARDS who were enrolled. And the umbilical cord mesenchymal stem cells were expanded in a GMP facility, cryopreserved until needed, and then prepared for IV injection in the patient. Patients required 2 infusions 72 hours apart, acquiring 100 million umbilical cord mesenchymal stem cells each time. So here is their inclusion and exclusion criteria. So for inclusion criteria, patients had to be hospitalized for COVID-19. They had to be more than age 18. They had to have a peripheral capillary oxygen saturation of less than 94% on room air or requiring supplemental oxygen. They had to have a PO2 to FiO2 ratio of less than 300, which is definition for acute respiratory distress syndrome or ARDS, and bilateral infiltrates on chest radiograph or bilateral ground glass opacities on CT. And exclusion criteria included a previous history of mesenchymal stem cell infusion unrelated to this, pregnancy, lactation, arrhythmias, patients with previous lung transplants, those undergoing dialysis, those undergoing ECMO, patients who have an active malignancy except those with non-melanoma skin cancer, severe liver disease, chronic respiratory failure, QT prolongation, or a very, very ill patient that had a limited life expectancy. And so preliminary endpoint in this study was safety, and this was achieved, whereby no serious adverse events were noted post-mesenchymal stem cell infusion. So ultimately it was found that this therapy was found to be safe. So next they wanted to see, did mesenchymal stem cell therapy lead to improved patient survival over the course of 30 days? And the green curve shown here shows patients who underwent mesenchymal stem cell therapy as compared to the control group, which was patients who received standard care at that time. And it was found that after 30 days, 91% of the patients survived who received mesenchymal stem cell therapy compared to only 42% in the control group. And then they looked at, was mesenchymal stem cell therapy treatment associated with improved time to recovery? And they found that by day 30, patients who were treated with mesenchymal stem cells, the green group, demonstrated improved time to recovery as compared to control, which was the orange curve. Then they looked at survival. And it was interesting to note that they found that when they looked at survival by day 30, 100%, yes, 100% of the patients aged less than 85, which is the cutoff that they used, survived. When they looked at survival at 3 months post-infusion, they found that patients who were treated with mesenchymal stem cells did better as compared to the control, looking at the green versus the orange curves, respectively. Now, they also did a cytokine analysis where day 0 was defined as right before mesenchymal stem cell infusion and at day 8 and at day 6. And they observed statistically significant decrease in pro-inflammatory cytokines, chemokines, and growth factors, which were involved in cytokine release syndrome post-mesenchymal stem cell therapy. So let me walk you through this. So this is day 0, defined as right before infusion, and then day 6, 6 days after. So as you can see, treatment resulted in a decrease in the pro-inflammatory cytokines shown here, and chemokines. And this was essentially universal across the board, thus showing the profound efficacy that mesenchymal stem cells have. But this study was limited because cytokine testing was limited because they didn't do a full panel. For example, in the models that we proposed and showed, along with others in the field, cytokines like IL-10 were missing. And so when looking at these results, mesenchymal stem cell therapy was found to be safe. There were really no adverse events, and it was associated with improved patient survival, 91% at 1 month versus 42% at 1 month in patients who did not undergo mesenchymal stem cell therapy, and also improved time to recovery along with survival. Now, most recently, the Icahn School of Medicine at Mount Sinai published on their own clinical trial, which assessed the efficacy of Remestemcel-L, which is a mesenchymal stem cell product from mesoblast, in a cohort of 11 patients who had severe COVID-19. And then mesenchymal stem cell therapy resulted in quicker time to extubation, 10 days, and discharge with a rapid decline in their inflammatory marker profiles. So, future directions. So, when applied to our COVID-19 cancer model, mesenchymal stem cells should inhibit IL-6 at multiple points within the indicated pathway, as it decreases IL-1 and increases IL-10. This can then further act to dampen IL-6 expression, which then further decreases the pro-inflammatory pathways. The ultimate goal here, and I just want that to kind of be clear, is to treat SARS-CoV-2 quickly and efficiently, because we want to minimize long-term consequences so that patients plagued by malignancy can resume their respective anti-cancer therapy quickly and minimize any interruptions. And what makes mesenchymal stem cells unique is, unlike a single agent like an IL-6 inhibitor, they act on all the pathways simultaneously, the big pathways, the small pathways, and they are able to significantly affect IL-6 expression, IL-6 production, and IL-6 downstream effects simultaneously. In addition, they possess antiviral properties that can halt replication of SARS-CoV-2 in the direct pathway. So ultimately, they're able to affect both the direct and indirect pathways simultaneously. And so, in conclusion, we propose a cohesive mechanism of action for SARS-CoV-2, a model to explain the interplay between severe SARS-CoV-2 and cancer, along with a promising therapeutic intervention, that being mesenchymal stem cells, and their molecular efficacy to control SARS-CoV-2 in cancer patients. Before I conclude, I want to acknowledge the great individuals that contribute to this work. I'm blessed for the mentorship that I received from Drs. Park and Sharma, and it was a pleasure to work with all the co-authors. I also want to thank the organizers of this event. Thank you so much for having me. And to you, the audience, thank you for your attention, allowing me to showcase our work. Thank you.
Thank you very much, Dr. Leyfman. As with all the talks, we are likely going to have lots of questions from the audience. I can see we have received some questions already, so I'll move straight on to the Q&A now. For the first question, what makes mesenchymal stem cells so robust?
So their robust efficacy really stems, as I had shown here on the slide, from their ability to target all the pathways simultaneously. Additionally, these cells are relatively easy to procure, and they're not all that expensive. So the infrastructure to maintain and develop them is manageable, and along with their cost. And so because of that, they present a promising therapeutic intervention, and that was shown in the clinical trials that previously spoken about.
Thank you. Moving on to the next question. Many promising therapies are plagued by financial toxicity. What is the cost and manufacturing challenges of MSCs?
Right. So MSCs as a whole, it costs about several $1,000s to produce. And then from a patient standpoint, I don't envision them costing more than several $1,000s. What is also unique is where they come from. So they can be derived from umbilical cord, placenta, and also human fat. One placenta can be used to treat about 200 patients. And right now, there are several companies exploring the efficacy and ability to extract mesenchymal stem cells from human fat and then utilize them as therapeutic interventions. And preliminary data that they had shown has been very promising.
You had spoken about the promise of MSCs. Do they have applications beyond COVID-19?
Yes. So recent studies have shown that they have shown efficacy in patients who are undergoing bone marrow transplants. It improves engraftment. Some studies have shown that they have a profound ability to improve outcomes in patients post-stroke, post-heart disease, post-myocardial infarction, and even have been shown to have efficacy in patients who have chronic pain syndromes and chronic inflammatory conditions. And so they have a lot of versatility, and we're just scratching the surface of their potential.
Thank you, Dr. Leyfman. We have some time to answer one final question. Given the promising work that you had demonstrated, what do you hope for the next steps to be?
So my hope is we can find ways to help patients who are immunocompromised so that they don't have to, let me show. So during the height of the pandemic, patients who are immunocompromised, like those with malignancy, had interruptions in their therapies. Because of that, it's important that we provide them with respite now that we are 3 years post the first wave of COVID. With that, I hope that this work can lead to the opening of clinical studies and clinical trials that can further explore the efficacy of these cells in patients who are immunocompromised and be used as hopefully a therapeutic to offer hope and lasting results so that those patients don't need to compromise on their life-saving therapies while managing COVID. Hopefully that comes to fruition.
Thank you so much, Dr. Leyfman. Unfortunately, that's all we have time for today. Any questions that we didn't have time to get to will be sent to the speaker after the event. As with all other talks in the event, this talk will now be available to view whenever you want for the next 30 days. That just leaves me to say thanks again, Dr. Jan Leyfman, and we'll be back soon with the next talk.